Today we're going to be taking a look at Parkinson's disease, which is another video in our clinical neurology series. As a starting point, we can define Parkinson's disease as a neurodegenerative brain condition which occurs due to disrupted dopamine pathways within the brain. And to fully understand the condition, we first have to take a step back and remember the basic anatomy of the brain, where we have the outer structures including the cerebral cortex, as well as more inner structures including the thalamus and the basal ganglia. And it's the basal ganglia which is the part of the brain primarily responsible for motor control within the body. If we take a cross-section of the brain at the level of the basal ganglia, we can see that it's composed of different parts, and this includes the caudate nuclei, the thalamus, which was also present on the previous diagram, the putamen, as well as the substantia nigra. And it's this substantia nigra part of the basal ganglia which is most commonly affected in Parkinson's disease. One important point to note is that the substantia nigra can be divided into two main parts, which include the pars reticulata and the pars compacta. And these different structures within the brain basically interact to allow normal movement to take place. One of the main pathways runs from the caudate and putamen to the pars reticulata, and then from the reticulata to the thalamus. And this pathway is governed by a neurotransmitter called GABA, which is the main inhibitory neurotransmitter within the body. The second pathway runs from the pars compacta to the caudate and putamen, otherwise termed the striatum, and this is known as the nigrostriatal pathway, which is basically governed by dopamine. Signals from the caudate and putamen are then sent to the cerebral cortex, which allows for stimulation of movement. Importantly, it's the substantia nigra pars compacta part of the brain, and therefore the nigrostriatal pathway, which is commonly affected in Parkinson's disease. In terms of the pathophysiology of Parkinson's disease, there are basically two main changes which occur. The first is that there's a loss of dopaminergic or dopamine transmitting neurons within the substantia nigra, and these neurons undergo progressive neuron death. The second main change is that there's a buildup of a protein called alpha-synuclein within the neurons, which is also termed Lewy body deposition. To illustrate the effect of both of these changes, we can look at what happens in a normal synapse, where there's a good level of dopamine circulating between one end of the synapse and the other, and this allows for normal motor control. Comparing this with Parkinson's disease, the buildup of alpha-synuclein combined with the loss of dopaminergic neurons results in less dopamine flowing from one end of the synapse to the other, and this results in impaired motor control, which leads to the symptoms of the condition. Turning towards the features of Parkinson's disease, there are a series of core symptoms which are important to know about, and these include a unilateral tremor, so a tremor on one side of the body, increased rigidity, so sometimes described as cogwheel rigidity, where patients are more stiff than normal, bradykinesia, which is basically used to describe slower movements compared with normal individuals, and postural instability, and these patients are often predisposed to recurrent falls over time. There are also some additional symptoms to be aware of, which include olfactory changes, so changes to the sense of smell, reduced facial expression, a Parkinsonian gait or a shuffling gait, which is a bit slower than normal, cognitive impairment, as well as some mood disorders such as anxiety and depression, as well as disturbances to sleep. Importantly, it's the non-motor symptoms which typically develop before the motor symptoms, but these are often more difficult to spot, which results in delayed diagnosis in most individuals. So what exactly causes someone to develop Parkinson's disease? Well, in reality, there's no single cause behind the condition, but there have been multiple risk factors that have been identified. And these include increasing age, being male, a family history of Parkinson's disease, as well as genetic factors. And if we hone in on the genetic factors, there have been some genes that are thought to be related with Parkinson's disease progression, and these are listed below. Going through some of them, we can see that the SNCA gene codes for the formation of alpha-synuclein. So in patients where this gene is overexpressed, there might be more alpha-synuclein than normal, which increases the risk of PD development. The next gene, PARK2, codes for Parkin protein or protein recycling. So when this gene is impaired, it can result in alpha-synuclein building up again. The remaining 3 genes are involved in protecting against mitochondrial stress. So when these genes are impaired, there might be more neuronal cell death than normal. The diagnosis of Parkinson's disease is usually based on clinical signs and symptoms, as well as an examination performed by a trained neurologist. However, it is important to rule out other causes behind the symptoms, which can include possible infections, electrolyte changes, and a benign essential tremor in patients where a tremor is the main presenting complaint. In some instances, imaging may also be performed, and this usually involves a dopamine transporter scan or a DAT scan, which looks for neurochemical changes associated with the condition. And just as an example, we have an image of 3 different brain scans showing a healthy control, early Parkinson's and advanced Parkinson's, and the main change to note is that there's reduced striatal dopamine availability according to these scans in Parkinson's disease. Once the diagnosis of Parkinson's disease has been made, it's important to manage the condition closely, and the first-line medication is usually a drug called levodopa. To fully understand how levodopa works, it's important to return to the blood-brain barrier, which is basically a system of filtering molecules from the blood into the brain. In an ideal world, we'd want to give Parkinson's disease patients dopamine directly, but the issue is that dopamine does not cross the blood-brain barrier. So instead, we have to use the precursor to dopamine, which is levodopa, and this is able to cross the blood-brain barrier. Once it's across, levodopa is broken down into dopamine by an enzyme called dopa decarboxylase, and this helps to improve the levels of dopamine within the brain. One issue which was noted when levodopa was first introduced was that there is actually some dopa decarboxylase present in the blood as well, and this ends up breaking down levodopa into dopamine before it even reaches the brain. With higher levels of dopamine circulating in the blood, this can lead to side effects such as nausea and arrhythmias. To counteract this effect, a new drug called carbidopa was also invented, which helps to block peripheral dopa decarboxylase, thereby preventing the breakdown of levodopa to dopamine within the blood. And this allows more levodopa to cross the blood-brain barrier instead. For this reason, levodopa is often combined with carbidopa to reduce the side effects of the drug. Another group of medications used to treat Parkinson's disease are the MAOB and COMT inhibitors. And to explain how these work, both levodopa and dopamine are broken down by 2 enzymes in particular, which include monoamine oxidase B and COMT. And these enzymes work in conjunction to break down levodopa into its constituent molecules. As a consequence, we can use these enzymes as targets for treatment, so we can use monoamine oxidase B inhibitors such as selegiline and rasagiline, or COMT inhibitors including entacapone and tolcapone. And with these enzymes blocked, we can prevent the breakdown of levodopa and allow the levels of dopamine to increase within the brain again. So the medication essentially works by inhibiting the degradation of L-dopa. A third class of medication used to treat Parkinson's disease are the dopamine agonists. And to explain how these work, we can look at the synapse again, where we can see in Parkinson's that there's reduced levels of dopamine circulating from one end of the synapse to the other. We can use dopamine agonists such as bromocriptine and rotigotine, which essentially stimulate dopamine receptors and mimic the effect of dopamine to improve the symptoms of the condition. Note that in this case the levels of dopamine aren't increasing themselves, but we trick the synapses to think that there's more than there actually is. There are also some other medications which can be used to help with the symptoms of Parkinson's disease. For example, there are anticholinergics, which basically help to improve the level of dopamine and acetylcholine balance. And there's a drug called amantadine, which is actually an antiviral agent that has been associated with improved dopamine signaling. These medications are often combined with L-dopa to exhibit their full effects. Finally, in some patients, deep brain stimulation may be offered, and this is basically a procedure which involves the insertion of electrodes into the affected brain region with an impulse generator battery inserted into the chest. And this device can be switched on or off by the patient to help to control some of the symptoms, including tremors or rigidity. It's important to note that there's no definitive cure for Parkinson's disease currently, and the treatments are mainly focused on trying to improve the symptoms as opposed to stopping the neurodegeneration over time. And here we have a quick summary slide outlining everything I've gone through in the video. I hope you found this helpful, and I'll see you in the next one.